Welcome everyone, and thank you to those joining us live and to those listening in afterwards. I would also like to warmly welcome our speakers today, whom I will shortly introduce. Our digital event today is titled Reframing the Role and Impact of Pharmacy in Chronic Disease Care. Chronic non-communicable diseases, or NCDs, such as cancer, chronic respiratory diseases, cardiovascular diseases, and diabetes represent a worldwide health challenge. And according to the World Health Organization, 41 million people die each year from NCDs, accounting for 74% of all deaths globally, and 15 million of which occur between the ages of 30 and 69. So the non-communicable diseases, NCDs, represents a major challenge to health systems of all countries, regardless of their wealth or state of development, with 77% of all NCD deaths occurring in low and middle income countries. Prevention and management of chronic diseases is depending on reducing underlying risk factors, and community pharmacists and their teams are ideally placed to raise chronic diseases awareness, identify those at risk, and can be the driving force behind earlier detection and referral to primary care partners for screening, diagnosis, and intervention. And at this event today, the Chronic Disease Service Framework to support pharmacists in providing a range of NCD pharmacy services will be presented. And the prevention and management of NCDs require interventions that must be effective, cost-effective, affordable, and feasible, and should be included in national policies and supported by appropriate indicators of NCDs and their risk factors. And such interventions should promote health equity and be designed to target populations and individuals to promote health outcomes. Our speakers today will present practical toolkits that will equip you with the tools and strategies you need to effectively manage chronic conditions in your pharmacy. For those of you who don't know me, my name is Lars-Åke Söderlund, and I have the honor and pleasure of moderating this event today. I am one of FIP's vice presidents, and I'm also co-chair for the FIP Technology Advisory Group. On a daily basis, I work as an executive advisor for Apoteket, a government-owned pharmacy chain in Sweden. Today, the Turkish Pharmacists Association, one of FIP's member organizations, offers a Turkish translation available on Zoom by clicking on the translation icon on your screen. Thank you so very much for your support from Turkey. And as you can see on this slide, we have some announcements. Please note that this event will be recorded, live streamed on FIP YouTube, and the recording will also be available at FIP events, fip.org. To all those listening, please feel free to send your questions through the Q&A box provided, and I will do my best to manage all the questions so that at the end we will be able to address those questions. And you're also welcome to provide feedback to webinars at fip.org. And I would also like to take this opportunity to promote the benefits of membership with FIP, including events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. So if you're a pharmacist or a pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. This digital event is supported by an educational grant from AstraZeneca. Thank you so very much for your kind support. For this event, we are joined by a panel of fabulous speakers, and I want to sincerely thank each of them for taking the time to prepare their presentation. And with us today are Ines Nunes da Cunha, FIP Practice Development and Transformation Projects Manager from the Netherlands, Antonio Teixeira Rodriguez, Director, Evidence and Health Solutions from the National Association of Pharmacists in Portugal, and Jack Chen Lim, General Secretary from the Malaysian Pharmacist Society from Malaysia. Welcome all of you, and it is indeed a great honor to having you with us today. And here we have today's program. Our invited speakers will cover the following topics: pharmacists as early interventionists in chronic diseases management, practice integration of the chronic disease service framework, reframing the role and impact of pharmacy in chronic diseases care, insights from Portugal, and reframing the role and impact of pharmacy in chronic disease care with insights from Malaysia. And then we will have the Q&A session and some wrap-up and conclusions before we end this session. There are a number of learning objectives for this webinar today. You will learn about the global burden of chronic diseases and their risk factors, recognize the critical role that pharmacists can play in early intervention of chronic diseases, identify opportunities to facilitate awareness and screening of chronic diseases in at-risk patient groups, and develop a clear understanding of how to seamlessly integrate the chronic disease service framework into practice. Chronic diseases, or non-communicable diseases, NCDs, as they are broadly defined as, are conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living or both. And these multifactorial diseases affect patients from all walks of life and in all parts of the world. So chronic diseases cause the highest disease burden worldwide, and globally greater than 2 in 5 of all adults are diagnosed with typical chronic conditions and defined as the presence of one or more than one chronic disease. And the 4 major types of chronic diseases include cardiovascular diseases such as hypertension, heart failure, and stroke, chronic respiratory diseases such as chronic obstructive pulmonary disease and asthma, cancers, and diabetes. And globally, chronic diseases have become the leading causes of mortality and disability, challenging both population health and healthcare systems. And several chronic diseases have been prioritized by the World Health Organization, including cardiovascular diseases, cancer, chronic respiratory disease, and diabetes, which significantly contribute to mortality and disability. 41 million people die each year from chronic diseases, accounting for 74% of all deaths globally. And 77% of all chronic disease deaths occur in low and middle income countries. And 17 million people die annually from chronic disease before the age of 70 years, with 86% of these premature deaths occurring in low and middle income countries. And cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes account for more than 80% of premature chronic disease deaths. Chronic diseases are caused by a combination of genetic, physiological, environmental, and behavioral factors. And the slide shows the most common behavioral and metabolic risk factors that prematurely place patients at risk of a chronic disease. And prevention and management of chronic diseases is dependent on reducing underlying risk factors. Monitoring these patient risk factors can also help support early identification of a chronic disease. Pharmacy is a natural ally in the global fight against chronic diseases, and there are multiple touch points within the pharmacy that provide opportunity for pharmacy teams or pharmacy team members to impact patient care. Routine pharmacy services might reveal patient risk factors for chronic disease or existing chronic disease symptoms, making them ideal touch points for further patient counseling and referral. And pharmacists can provide initial counseling on what a specific chronic disease is, the risk a patient might have of developing a disease, and why it is important to get tested, how they can get screened, and what symptoms to monitor for. According to the World Health Organization, detection, screening, and treatment are key components of chronic disease management. Although the extent of the involvement of pharmacists in chronic disease care may vary depending on the country in which they practice, community pharmacists are well positioned to deliver many early identification and timely intervention measures and refer to primary care when appropriate. Now I would like to introduce the first speaker, who will be presenting on pharmacists as early interventionists in chronic diseases management, practice integration of the chronic disease service framework. And our first speaker is Ines Nunes da Cunha. She is the FIP Practice Development and Transformation Projects Manager. And before joining FIP, Ines worked as a community pharmacist for more than 14 years and taught for 6 years at the university as professor in the Integrated Master in Pharmaceutical Sciences in Portugal. She got a master's in pharmaceutical care and a PhD in pharmacy from the University of Granada in Spain. And she is the author of several publications focusing on the area of pharmacy practice, especially related to patient-centered care in FIP. Currently, she works as the FIP Practice Transformation Program lead on non-communicable diseases. Welcome, Ines. It's a great pleasure to have you as our speaker today, and welcome to give us your presentation.
Thank you so much, Lars-Åke, for the kind introduction, and good morning, good afternoon, or good evening to everyone joining this webinar today. For me, it is a great pleasure to share with you the important work FIP has been doing in the field of chronic diseases, or NCDs. And I am excited to introduce you a new framework designed to motivate and empower community pharmacy teams to establish comprehensive community-based chronic disease services. So FIP has been working in the field of NCDs for several years as part of our commitment to the World Health Organization EFTANA Declaration on Primary Healthcare, signed in 2018. And one of the ways FIP has been doing this is through the FIP Practice Transformation Program on non-communicable diseases. This program aims to provide tools and strategic supports to FIP member organizations to develop and implement pharmacy services that can have a sustained positive impact in the prevention, screening, management, and treatment optimization of non-communicable diseases for improved patient outcomes and health systems efficiency and sustainability. The program initial focus on 5 disease areas that you can see on the slide: cancer, cardiovascular diseases, chronic respiratory diseases, diabetes, and mental health, but also on risk factors for these diseases, such as tobacco use, stress, alcohol consumption, and nutrition. FIP has several publications in the area of non-communicable diseases, including 5 handbooks for pharmacists in the 5 disease areas I mentioned, and also 5 knowledge and skills guides, which describes the knowledge and skills pharmacists need to provide effective chronic disease services in these 5 disease areas. We also have several publications in the area of tobacco cessation, including a handbook for pharmacists and also a knowledge and skills guide. All these publications are available on the FIP NCDs microsite. You can see the QR code in the top of the slide, and if you want, you can scan the QR code right now and you can go directly to this microsite. And several examples of the positive impact that community pharmacies and pharmacists can have on the health of people with chronic diseases can be found in all of these publications. Community pharmacists are already acting as primary healthcare professionals in many countries, and pharmacists can provide targeted interventions, specialized advice, and care coordination. Pharmacists can help improve patient engagement and medication adherence to achieve better outcomes in the global fight against chronic diseases. So now I would like to invite you to reflect on your own practice and to take a moment to answer the question you can see on the screen. So, do you speak to patients about their chronic disease risk and or management? A, Yes, I regularly and consistently perform these activities at a level I am happy with. B, yes, I occasionally discuss chronic disease risk and or management with my patients, but I would like to do more to help my patients. C, no, discussing chronic disease is not part of my typical practice. And D, no, I am unsure of where to start. So I will give you 30 seconds to think about this question, to reflect on your own practice, and you can answer if you want in the chat. On the chat, you can leave your answer. To let us know what is your type of practice. So while most pharmacists and pharmacy teams members would like to answer A, many may not. They may only occasionally speak to their at-risk or diagnosed chronic disease patients, or they may not know where to start. But the good news is that now there is a chronic disease services framework to help community pharmacist teams start the chronic disease conversations and make their moments spent with patients matter. The chronic disease services framework has been designed to enhance patient interactions and minimize the burden on workflow and workload in community pharmacies. This framework supports community pharmacy teams in effectively identifying patients at chronic disease risk and providing motivational counseling to empower those who will benefit from chronic disease assessment and management. You can access to the chronic disease services framework through the FIP NCDs microsite. You can go to our microsite. You can click on the main disease areas. You can also click chronic disease care, click on toolkit, and you have all the framework materials available. Or if you prefer, you can now scan the QR code you can see on the top of the slide, and you can go directly to the chronic disease service framework, and you can download all the materials available. So the chronic disease service framework is a cross-therapeutic approach to chronic disease care within the pharmacy. The services framework is an opportunity for pharmacy to play a meaningful role in the management of chronic disease by enhancing the quality of patient interaction, optimizing collaboration within primary care, and improving the health of their community. And you can see on the slide that the framework consists of two key components. The first one is the chronic disease services initiation toolkit that I will exploring in deep during this session, and the various chronic disease state pharmacy toolkits. And we have available three disease state pharmacy toolkits: the chronic kidney disease, the heart failure one, and the COPD toolkit. The initiation toolkit was designed to motivate and support community pharmacist teams to establish or enhance a community-based chronic disease screening and management program. The initiation toolkit has four core elements that aim to upskill pharmacy teams in the value of a standardized approach to chronic diseases and to operationalize this program in the pharmacy, collaborate with prescribers, and promote such services to their patients. And the first element is the chronic disease services e-learning module. This learning module introduces the initiation toolkit and disease state pharmacy toolkit, the three that I have mentioned before, and describes how to integrate those elements into everyday pharmacy practice. The second document material is the chronic disease services implementation checklist. This is an operational checklist providing a summary of considerations when deciding to start or expand the chronic disease services, and or explain how to effectively integrate the services into day-to-day workflow. You have also available the chronic disease services promotion poster. This is a print-on-demand poster that informs patients to initiate a conversation with a pharmacist or pharmacy team member about their chronic disease risk and or current chronic disease. Finally, we have the chronic disease prescriber services promotion letter. This is also a print-on-demand letter addressed and sent to a local prescriber outlining pharmacy-based chronic disease services and how partnership can enhance community health. So I will now provide a more detailed overview of each of these four elements within the initiation toolkit. So the chronic disease care e-learning module is a self-study module that is recommended to be completed by all pharmacy staff who will be participating and helping to deliver the chronic disease services program. This model was designed to highlight the accessibility and value of pharmacists in chronic disease management, establish why a standardized, streamlined approach to chronic disease can maximize patient interaction. And in this module, you will find several chapters with content to help you better understand what are chronic diseases, the role of the pharmacist in chronic diseases, and what is the chronic disease framework itself and how you can use it. At the end of the learning module, you will also find some case studies, key learning, and a glossary of terms that will help you. The second element is the service implementation checklist. That is an operational checklist that is expected to be completed by a pharmacy decision maker, such as a manager, a pharmacy manager, or the owner of the pharmacy. This checklist was designed to provide a self-evaluation or a pharmacy audit tool in preparation for starting or expanding chronic disease services effectively, and provides an easy-to-use guide that helps set the team up for success. This checklist provides a list of key considerations and the strategic steps to review if your pharmacy plans to start or expand pharmacy-led chronic disease management services. This is not an exhaustive checklist. It is meant to serve as a simple and practical guide to help prepare your team for offering a sustainable and impactful services. And this checklist, as you can see on the slide, include questions regarding pharmacy staff, physical space, technology or tools available, operations or workflow services, sustainability, service demand, promotion, and collaboration. So you can have several, in the checklist, several points that you need to check if your pharmacy is prepared to implement the services. Then we have the chronic disease promotion poster. And this poster, you can see on the slide, that starts with a provocative statement about chronic disease directed at patients. So the statement is, are you living with a chronic condition? And did you know that every 2 seconds a person dies prematurely from a chronic disease? So this is a call to action, and this call to action encourages patients of the pharmacy who have been diagnosed with one of the listed chronic conditions to speak to their pharmacist or a member of the pharmacy team. And the poster also outlines how the pharmacist can support the patient in the chronic disease journey. So pharmacy team members should print this poster and place the poster in a visible location for their patients to see and respond to the poster call to action. This poster is designed to enable the pharmacy to take advantage of in-store marketing by informing all patients and customers who visit the pharmacy about the value of chronic disease services delivered by their trusted pharmacies. And the good news is that this tool will take less than 3 minutes to print and place in an appropriate location in your pharmacy. And at last, we have the prescriber services promotion letter. This is a referral letter addressed to the patient's primary care physician and outlines the purpose and value of these services to mutual patients. It also explains why the pharmacy team aims to improve collaborative community health care and the potential for referrals of patients to the prescriber for further care. The pharmacy manager or the pharmacy owner will personalize the letter to the prescriber and adds their pharmacy information with their name. This letter can be printed and mailed, or if you prefer, you can convert to a PDF and email to the prescriber. This material was designed to foster collaboration with prescribers in the community and to set expectations with respect to pharmacy-based chronic disease services. And also, this letter should take less than 3 minutes to be completed and to send to the prescriber. So, as I mentioned earlier, the chronic disease service framework has 2 components: the chronic disease service initiation toolkit that I have explained you, and also the chronic disease state pharmacy toolkit that so far we have 3. The CKD1, the heart failure, and the COPD. And all of these toolkits, these 3 toolkits and the general one are available on the FIP NCDs microsite. And each of these toolkits also consists of several elements, but in general, for each disease, you will find also a disease state e-learning module that is customized to a specific disease state. You have a disease state assessment tool developed to be used by pharmacists and pharmacy teams members to support patient counseling about the risk of a disease, the condition itself, how patients can be screened, and or how the disease can be managed. You have also a patient information leaflet. This leaflet summarizing important information for a patient, such as what is the specific chronic disease, and now if left untreated, there can be serious complications in the future. So this is information for patients. And you have also a primary care referral letter. This is a different referral letter. This is specific for patients with a specific condition. This is a document that simplifies documentation and the referral process. This letter explains why your pharmacy is contacting the physician and how you can work together to support the patient. The resources in the chronic disease services framework can be used alone or in combination to support the initiation, expansion, and delivery of pharmacy-based chronic disease services. An infographic was also developed. You can also access this infographic on the microsite, and this infographic is a one-page digital visual aid that serves as a quick reference guide on where, when, and why to use the chronic disease pharmacy framework in pharmacy practice. You will find in this document quick links to the framework practice resources. In summary, this framework will help you to recognize and identify patients at risk of chronic disease or with a chronic disease condition, to start a conversation and take action with your patients, and also to collaborate with primary care. And by combining FIP resources with the chronic disease services framework, community pharmacists can be better supported in delivering effective chronic disease care. In conclusion, pharmacists as accessible primary healthcare providers are ideal place to support better management and outcomes for patients with chronic diseases. And as Lars-Åke mentioned in the introduction, there are multiple touch points within the pharmacy for at-risk screening and symptoms management interventions. So just one more note, the chronic disease services framework materials were commissioned and funded by AstraZeneca AstraZeneca have provided an educational grant to FIP to raise awareness and dissemination of this material in line with FIP mission to advance pharmacy worldwide. This material is aimed at pharmacists with an interest in chronic diseases, and I sincerely hope that this framework will empower and support you to provide chronic disease patient-centered care. So thank you very much. Back to you, Lars-Åke.
Thank you so very much, Ines, for sharing with us the chronic disease service framework and toolkit. And I agree, this material can definitely empower and support you as a pharmacist to provide chronic diseases patient-centered care. And also, as Ines mentioned, FIP has a large number of resources to support the delivery of NCD services by pharmacists. And this is the most valuable benefit of being a member of FIP as well. I will now move on to our next speaker. Our next speaker is Antonio Tejera Rodriguez, Director, Evidence and Health Solutions, National Association of Pharmacies in Portugal. Antonio has a PharmD in Pharmaceutical Sciences and is the Director of the Evidence and Health Solutions at the National Association of Pharmacies in Portugal. Antonio is also an invited assistant professor, School of Medicine at the University of Minho, and board member of the Center for Digital Health. He is also a researcher at Life and Health Sciences Research Institute at the University of Minho, and also at IMED at the University of Lisboa. Antonio, welcome to give us your presentation on reframing the role and impact of pharmacy in chronic disease care, insights from Portugal.
Thank you, Lars-Åke. Thank you very much for the introduction, and hello everyone. Thank you for FIP for the invitation. It's a great pleasure for me to be here, and actually it is a great pleasure to share with a panel of participants like this one some insights from Portugal. As we can see in the chat, we have people all over the world, which is great, and I hope the insights that I will give you are useful for your own practice too. Yeah. Okay. So just some introductory notes. Well, the project I'm going to talk about today, it aims to improve the role of community pharmacies in chronic disease management by empowering pharmacists and the pharmacy team itself to support patients with chronic conditions. And specifically here, we will talk about COPD, heart failure, and CKD, chronic kidney disease. And the interventions that we will talk about today in this project they are focused on education, on medication management, and also on personalized interventions made by pharmacists and led by pharmacists, ultimately aiming to improve the health outcomes and the patient's adherence to treatment. Well, it's also important to disclose that this project was developed in a partnership between AstraZeneca and the National Association of Pharmacies, and it is actually from this partnership, which includes a big research team, which I'm representing here today, that we are working on the development of these kind of interventions to implement in the community practice in Portugal. So, what do we aim with this project? Well, we want to implement and at the same time evaluate a pharmacist-led intervention which aims to update and increase the knowledge of the healthcare professionals working in the community pharmacies. We want to provide them tools to support patients to manage their disease. We want to promote awareness specifically in this project regarding focusing on these three diseases: COPD, heart failure, and also CKD. We want to empower patients with knowledge about their healthcare conditions, and we also want to increase the treatment adherence with the final aim to improve the health outcomes that patients can get from the use of their medicines. We also aim to identify and rectify potential medication-related issues, and finally, facilitate patient referrals for medical consultation when needed. We want to support pharmacists to be able to identify factors that make patients eligible to being referred for a new medical consultation. Okay, so regarding the project design, this figure aims to resume the project design, and we have adopted this multifaceted approach to chronic disease management. Actually, we have here three main parts. The first one, it's the pharmacy team training program. This one is quite aligned with some of the aspects that Inés told you before in her presentation, and it targets the pharmacy team itself. The second part and the third part are led by the community pharmacist itself. And the second one is the disease awareness and screening campaign. And here we want to target people at risk, which means that in the case of COPD patients, we want to target patients at risk of exacerbation. And in the case of heart failure and CKD, chronic kidney disease, we want to target people at risk of having these diseases. And in the last step, in the last part of this project, it is the medication management and the patient education program. And this one, as we will see later on this presentation, it targets specific patient groups. It is also important to emphasize in this whole project design that we have this evidence generation alongside the whole project. So we want to generate evidence about the value, clinical, and also some economic indicators, but mostly focus on the clinical outcomes that will emerge from this intervention led by the community pharmacists, because we believe that this evidence will also support in the future the decision makers to implement this kind of interventions in the practice, the routine daily practice in the community pharmacies in Portugal. Sorry. Okay, let's take a deep look on each one of the parts of this project. The first one is the pharmacy team training program. Here we developed this e-learning program and also some practical guides. And these practical guides are quite useful for the pharmacy team because they have the epidemiology of the disease, the most recent guidelines, the most relevant information that is being published for several organizations in Portugal and overseas, obviously. And it also includes this pharmaceutical intervention flow chart, which helps the community pharmacist to understand each step of his intervention to be implemented in community practice. The second part, the disease awareness and screening campaign, it has like two steps. The first one is the pharmacy identification of people at risk of heart failure and CKD, and in the case of COPD, at risk of exacerbation, and also the implementation of this educational intervention and provision of personalized counseling, provision of leaflets and other materials. Alongside the implementation of this campaign, we want to do this cross-sectional study, this epidemiological study, which will help us to characterize the population that we are working on. So the demographic characteristics, the clinical characteristics, the proportion of patients at risk, and other relevant clinical outcomes that we want to measure. The third part of this project is the medication management and patient education program. And this intervention is very focused on specific subgroups of the population that we are targeting in each one of the diseases, in each one of these diseases that we are working on. This is the longitudinal program with a baseline visit and a follow-up after 3 months visit. And alongside the implementation of this program, we will do this before and after study, again, an epidemiological study that aims to implement, to assess the impact of the program on drug-related programs, adherence to treatment, physician referrals, and other relevant outcomes. Regarding this disease awareness and screening campaign, which is the first step on the COPD arm of the study. So we start this work on COPD patients by inviting people living with COPD to participate in the program. And then we will implement a campaign, the disease awareness and screening campaign. And this first component involves the characterization of individuals participating in a campaign dedicated to raising awareness about COPD and its management. So it also identifies individuals at risk of exacerbation, as I told you, and are those suitable for a therapeutic regimen review through physician referral. The primary focus here are patients living with COPD. And the objectives, again, are to promote people's awareness, to identify and refer to physician when needed. So pharmacists will collect relevant signs and symptoms of alarm, or the signs and symptoms which may be associated with an uncontrolled disease like dyspnea, like the presence of respiratory disease, or the answer to questionnaires such as the modified MRC, which is a very relevant questionnaire to assess the severity of dyspnea in these patients. Again, as I told you before, alongside the implementation of the intervention, we will do this evaluation study. And here, specifically on COPD, we will collect data about the demographic characteristics, the severity of dyspnea, the MRC questionnaires, the smoking habits, the comorbidities, and the exacerbation history. And it is also objective of this study also to estimate the proportion of patients at high risk of exacerbation of COPD, to analyze the real-world treatment patterns for COPD patients, and also to describe process indicators which are relevant to characterize the pharmaceutical intervention implemented here. So if the patient, for those patients who are under triple therapy, we will implement the third part of the project, which is the medication management and patient education program itself. This second part of the initiative encompasses a longitudinal study designed to evaluate a program that targets individuals living with COPD and prescribed with the fixed dose triple therapy. This component, again, is designed to provide a comprehensive education and support individuals living with COPD and under treatment of this fixed dose triple therapy. So the objectives, again, are to promote awareness, to improve adherence to treatment, and also to identify and rectify potential medication-related issues. This program has two different appointments, the first appointment at baseline and the second appointment at 3 months. And based on the collected information that we will have, that the pharmacist will collect using validated questionnaires, the pharmacist should intervene by identification of non-compliance with therapy, incorrect use of inhalers, and also medication-related issues. On the second visit, again, 3 months after the first appointment, the following data will be collected: patient-reported outcomes like MMRC and exacerbation history, the current COPD pharmacological treatment, the score of inhalation technique, which is a very important process indicator to understand how these inhalers are being used by patients, the self-reported evaluation of adherence, the persisting drug-related programs, new drug-related problems that can come up in these 3 months, and also to reassess the vaccination status and the smoking status. And based on, again, on this collected data, the pharmacist will be available to identify non-compliance issues, incorrect use of inhalers, medication-related problems, smoking cessation, promote vaccination when needed and applicable, and promote the adoption of healthy lifestyle habits. And this is the details of the interventions that we want to implement here. On the other side, when we talk about the CKD and heart failure project, we will start by inviting persons recognized as being of particular interest for risk assessment for heart failure and CKD. And one of the characteristics, for example, is the persons being aged 40 years or older. So CKD and heart failure emerge in these particular populations as a prevalent condition. Often they are associated, and they demand for effective identification and management strategies to address the symptoms, the disease progression, and the improve health outcomes for those grappling with these pathologies. And because of that, for those patients eligible for the study, we will implement this disease awareness and screening campaign, like similar to the one that we did for the COPD arm of the study. We will promote the awareness of CKD and heart failure, and we'll also identify individuals at risk for heart failure and CKD. We will do this through the application of a questionnaire to collect data for risk assessment. We will implement this educational intervention supported by a leaflet to the person, and if justified, we will encourage and refer the patient for medical consultation. For those individuals, with on the participants of this arm of the study, for those individuals being treated with SGLT2 inhibitors, they will be eligible for the second part of this program, which is the medication management and patient education program, again similar to the one we did for COPD. Here, the objectives of this medication management and patient education program are to improve therapeutic adherence to SGLT2 inhibitors, to recognize, address, and proactively prevent issues related to medication. We want to empower patients with knowledge about heart failure and CKD, including, and one of the most relevant aspects here is including empower them to recognize early signs and symptoms associated with these diseases. We want also to empower community pharmacists to support these individuals with these diseases, and also to facilitate patient referrals for medical consultation. Here, again, we will implement a longitudinal program with 2 visits, one at baseline and the other one 3 months after the first appointment. The first visit, we will collect data, demographic data and clinical characteristics data. We will collect data about the current pharmacological treatment with SGLT2 inhibitors and the other relevant medication. We want to collect data about patient-reported outcomes, such as the adherence, knowledge of heart failure and chronic kidney disease, and other relevant patient-reported outcomes, and also some important process indicators, such as if each one of the individuals is referred or not to the patient. Based on this, to the physician, based on all this data collected, the pharmacist, again, similar to what we did in COPD, will be able to intervene, to identify non-compliance with therapy, to identify low level of knowledge about the pathology or inadequate self-care measure, inadequate lifestyle habits, and also to promote the adoption of healthy lifestyle habits, and also to identify incomplete vaccination status, and again, promote the vaccination status. Specifically here, we will also share some SGLT2 inhibitors leaflets to give the patient and empower patients with knowledge about the therapy that they are using. In the second visit, in the second appointment, the pharmacist will again collect all this information, the demographic, clinical, pharmacological treatment, patient-reported outcomes, and which will allow us to assess the evolution of the adherence, of the knowledge, and the other relevant outcomes regarding the way they deal with the symptoms or the potential disease of having the idea of having heart failure or CKD, and also the process indicators. And again, the pharmacist will make a second intervention at this point based on what he or she identifies as non-compliance issues, low level of knowledge, inadequate lifestyle habits, again, or incomplete vaccination status. So again, the design is quite similar to the one we saw for COPD, but this one is specifically focused on CKD and heart failure. The knowledge, materials, and intervention obviously is also adapted to that. So to conclude my presentation, I'd just like to share that by integrating pharmacies more deeply into this chronic disease management, this project, and we believe that this project is not only empowering healthcare professionals, but also aims to improve patient outcomes. And we believe that this will emphasize the crucial role of community pharmacies in the continuing of care for chronic disease. Thank you, and Lars-Åke, I will
Thank you so very much, Antonio, for giving us an update on these actually very, very interesting projects and how to promote awareness of these diseases, as well as to empower patients with knowledge about their health conditions and to increase treatment adherence, improve the health outcomes. Very, very interesting. It is now time to move to our third speaker, who is Jack Chen Lim from Malaysia. Jack is a community pharmacist and the General Secretary of the Malaysian Pharmacist Society. And Jack has been a strong advocate of pharmacy nationally and regionally. Educated at Monash University in Melbourne, he began his career as a hospital pharmacist in Australia and transitioned through various roles in Malaysia, including manufacturing, industry, medical affairs, community pharmacy, business development, and technology. And he has been very active in promoting multidisciplinary health care approaches and policy reforms. And he serves on various national committees on drug policy, like the Malaysian National Medicines Policy, online health services and pharmacy practice, and he is the Vice President of the Federation of Asian Pharmaceutical Associations, FAPA. He also serves as an observer to the FIP Community Pharmacy Section Executive Committee. Welcome, Jack, to give us your presentation on reframing the role and impact of pharmacy in chronic disease care, insights from Malaysia.
Thank you so much, Lars. Thank you for the kind introduction. The usual good morning, good afternoon, and good evening to all our colleagues from around the world. I think there are quite a number of countries here represented, and I'll just jump straight into it. Essentially, what happens is I do want to refer our colleagues to FIP's current campaign on Think Health, Think Pharmacy, because what we are discussing today is actually very central to the strategy of preventive care as well as management of chronic care at the community level. So we want all our patients and their families and their carers, when they think health, they think pharmacy, and that's the way to go. So this Think Health, Think Pharmacy covers a large area, and this is something that is very central to what FIP is doing and what's the role of a community pharmacist. Also, I'm just go quickly on the on how the slides, the structure of the presentation. The MPS, which I represent, the Malaysian Pharmacists Society, we have already launched and rolled out the FIP Chronic Kidney Disease Toolkit, the CKD Toolkit. This is the first of the 3 toolkits that we're rolling out over time in conjunction with the FIP program, as well as being supported by AstraZeneca by AZAC in Malaysia. Because before we actually started and we start looking into the actual toolkits and what we can do with it, there were a few things we need to go through, which is whether CKD is actually a problem where a pharmacist can exist at the community level, as well as how can we adopt the FIP CKD toolkit for the local setting, community pharmacists in Malaysia to serve our communities. So zooming down to that level. So back when we look at the problem statement, we were looking at the problem, the solution, the result. And first, we wanted to identify whether CKD is actually a big enough issue, number one, and number two, whether pharmacists at the community level can assist. And so we did a little bit of background. We worked with our colleagues from the nephrology, from nephrologists, and we also work with the AZAC and our local pharmaceutical companies as well to look into the problem. And we look at chronic CKD to show that 1 in 10 have CKD with estimated death rate of 41.5%. So that's actually something very, very important to look at. Then we also did a study to see where pharmacists can sit. And when we looked at it, we look at it as a wider problem we have in Malaysia. In Malaysia, we have 500,000, or 2.5% of the adult population have 4 NCDs together. They have diabetes, hypertension, cholesterol, and obesity all linked into one. In Malaysia, about 15.6% have diabetes, 29.2% have hypertension, and more than 50%, myself included, is actually overweight or obese. And that's something that that we need to address. And looking at that, we went to our nephrologist colleagues and look at the dialysis data, and we look at the primary renal diseases for new dialysis patients. And we actually look at this and we realize that patients with diabetes and hypertension are actually very, very prevalent. In fact, if we look at it is about 86%. And which is actually very significant since in a sense what we are saying, 86% of new CKD patients have diabetes and hypertension. And diabetes and hypertension are chronic diseases that are regularly being treated at our community pharmacies, and our pharmacists engage their patients all the time when we dispense diabetic or blood pressure medication, as well as diabetes, blood glucose screening, as well as blood pressure screening. This is something that's really, really manageable at the community pharmacy level. So then we looked at this little diagram here, where we are showing the different 5 stages of chronic kidney disease or CKD. And essentially, as the number goes up, it gets more and more serious. And at the stage 5, it is end-stage renal disease. So our objective is to keep it in stage 1 and 2, and that's where we are looking at. So we are looking at this diagram here, where we start off with no clinical manifestation, and then with symptoms in the end increasing with the onset of morbidity. So where the pharmacists can play, it is in quite a number of areas actually, when basically in prevention and intervention, we can do promotive services or preventive services. Like promotive is like creating living conditions that support good health and health-seeking behavior. Preventive services is for prevention. And then, of course, we will have curative and rehab services and palliative services. And basically, this is actually where community pharmacies can play, and it's something that we believe that it is very useful for community pharmacies worldwide to actually evaluate and look at how we can actually roll out more and more chronic care services, with the main objective not actually curing it, because it's something that needs to be managed. It is to actually slow the progression, and that's very important. So we're trying to keep this on this side of the healthier side, rather than managing it or rehabilitative and palliative, which is by then far too late. Just to illustrate the point on our CKD, we actually went back to some work being done by Monash, that has been done by Monash University in Malaysia, and it's a program they call PRIME. And this is actually focusing on pre-diabetes, and they were looking at the Klang Valley, which is our capital city, and they're looking at the data, and they're trying to show whether that's a pharmacist intervention with an assistance of an app is significant. And the data actually shows that there are significant outcomes related to this, with weight, BMI, and BMR, because this is pre-diabetes, so blood sugar is not an issue as yet. And it actually shows that weight, BMI, and BMR actually is there's a significant difference between the control and the intervention group, as well as also adherence as well via engagement in the intervention group. And it actually shows that it's almost double when you talk about 5% weight loss in this program. And this is something that the good work that has been done by Monash University in Malaysia, together with a pharmacy chain here. And so in a way, this kind of proves what pharmacy can do, as a pharmacist, community pharmacist, how can we help, and that whether our assistance is significant. And this actually is one of those studies that shows that in this case for pre-diabetes, it is. So with this, we took this information that we have and our engagement with nephrologists, and we went and looked at CKD specifically. And the idea is to engage patients who are high risk to slow the progression of the disease significantly. And this is where we start looking at the toolkit that FIP has developed and provided, and we're adopting it and adapting it for the local consumption. Okay, so let's look forward into the actual adoption of the toolkit. So now I'm going to pivot a little bit to talk about how the MPS looked, how the society here worked with our community pharmacies as well as the pharmaceutical company to actually look at how we actually adopt this toolkit and putting it into place so that we can actually deploy it and effect a positive effect on our population. So we started off with, it's actually a 4-phase process, and we started off with localization. So basically, essentially, there is an algorithm and there is a protocol being presented to us by the FIP toolkit. And what we do as the first step of at the start of this is to actually see how well it matches the way we do things in Malaysia and the existing clinical guidelines, because it is easier for us to fit something in that is already with what is already in practice in Malaysia, rather than trying to adopt something totally alien to our ecosystem. So we work with our renal pharmacy special interest group within our society, which is part of our hospital and clinical pharmacy chapter. And we involve the specialist doctors, nephrologists, the clinical clinical pharmacists, and other experts. And we actually engaged the MSN, other associations as well. And we localized this toolkit into something that is more familiar to what we have in Malaysia. So if you look at this it's a very busy slide, but it's just something to show that on your left side is actually our 2 algorithms that is done by our Ministry of Health locally. This is for the doctors as well for practice in a clinical setting, which is hospital, government hospitals, or even private hospitals. And this is something that is not really part of our clinical pharmacy practice. And we were like trying to align this and see, well, are we interfering with this, or can we add to this? And on the right side, we actually have what was provided, the 2024 KDIGO Evaluation and Management of CKD Guidelines. And it actually looks at how we actually went and decide and look around with our experts, with the experts, to see how these two relate to each other. And we realized something very interesting, that whatever we do at the community pharmacy level will sit above. I said before this process, we are actually in the screening part, in the part where, because our end action for CKD is not to initiate treatment, it is referral. Okay, so if we detect a patient with CKD or getting worsening CKD, it's something that we refer to a doctor. So that's part of that process that we have assessed. And if you look at this assessment tool that was provided by FIP, which we adopt, right? This was after looking at this and comparing it to the earliest set of protocols that we already have that is recognized in Malaysia. It is easy to adopt this. And however, there was a part where we were not really sure of. It's because there is part of the protocol that say that we want to look into lab testing and all that. But because if we do that at the pharmacy level, and we may have to refer again, so we thought maybe that might not be the best thing. So that's something that we decided that we are KIV, keep in view, and see how it develops going ahead. But I will mention something about how we can actually assess it without the need of doing even any test on any blood test. Yep. So the second part of this, once we actually realize and recognize that there is a problem that pharmacy can fix and that we are the solution to stem in the gap, then now we have adopted and adapted it the guidelines and the protocols. Now we move on to the education part, and this is the education module that we set up, and we actually decided on a on-demand online module that pharmacists can do at their own pace. The reason why we went for this model instead of a talk or a physical talk or online talk is that most community pharmacists we noticed has a double peak work day. They are really busy during the lunchtime, 11 o'clock to 2 p.m. And the next part they're really busy is probably about 5 to 8 p.m. during dinner. This is where there are movement of people between work and home, and they're out to look for food, and that's where they stop by their pharmacies to fill their script or to look to seek for health. And this is where we decided that if we have it on demand, then the pharmacists at the community level can do this education part and learn more at that 2 to 5 o'clock time where, where you normally sit at the counter, twiddle your thumbs or check your stock or order for the next day. And that is where we actually developed and worked together with our partners to put it on a e-learning platform that's owned by the society and put it on demand. And we actually have some ways to go. When we put this out, there were a lot of responses. We have more than 1,200 people that comes in that looked at looked at this and are interested to do this. However, the issue was that the actual number that actually completed both sessions and the assessment as well is very, very low compared to that. It's about 100 plus. So we are still in the process of recruiting more and more pharmacists to actually do the CKD e-learning module. And I don't have the latest numbers with me today, but I hope that we can report back to FIP that more of these pharmacists are going, especially when we roll into more familiar NCDs. When we look at COPD, for example, or heart failure, or even moving to diabetes, right? Because CKD, it is something new as well that we are actually reaching out to our pharmacists about to monitor. Okay, so moving ahead, I'm quite conscious of the time. Then after we actually start to look into the education part, we move on to the activation. This is now where we are at, this is the phase we are at. We want to activate this to increase adoption by community pharmacists, as well as engaging patients, getting our pharmacists to engage patients, and that is the next area. And we are looking, and we already have designed, from my understanding, that we already have designs on materials in multiple languages to reach out to the population here, because we are multilingual. We speak English, Malay, Mandarin, Chinese, and the dialects, as well as Tamil, which is a Southern Indian language, based on our population here. So the collaterals are being produced to educate patients and encourage engagement of at-risk patients, which are the patients that have diabetes and hypertension. So we are looking into how we can adopt and actually roll this out as well. That's something that will be for Q1 next year. But in the meantime, while we were talking about this, this is actually something that we wanted to to actually highlight. And I think this is actually missing a little portion on the slide when it came over. This is actually a CDC score. It's called the Screening for Occult Renal Disease, a scored questionnaire. And this is a validated prediction tool used by CDC to estimate the risk of CKD in adults. And it is by calculation, it is not by lab testing. So it's something that we believe that at a community pharmacy is something that community pharmacists, when trained to do this, can easily give a very, very general view on whether you need to refer the patient and whether the patient is at higher risk of CKD. And it's as simple as getting the age, the gender, certain medical conditions that the patient has, what are the history, whether they have circulation problems in the leg, and so on and so forth. And with this, you can actually give a certain level of confidence to prompt the individual to seek a more comprehensive medical advice. And that is where we look at the referral letter that we are actually putting into place as well. So this will allow our pharmacists to refer easily to the GPs and the rest of the health system. Yeah. And last but not least, and we already started this, and from the society's perspective, is the public engagement. As I mentioned earlier, the translation of collaterals into the different languages. We are working already with the National Kidney Foundation, and effective from this year, we are now a regular participant going ahead, getting pharmacists into World Kidney Day in March, where usually there's activity that's being conducted in Malaysia. And of course, last but not least, with this, with any adoption of any toolkit, it is also very mindful for us to look at reviewing it. So as we roll this out, we are looking at the numbers of engagement with pharmacists, translating to numbers of engagement with the patient, and then we'll see how we can do to actually link it back to review how successful this is, and if need to, we can actually adjust things accordingly, even as we roll out further toolkits to support NCD services. So in conclusion, my key take-home messages are, number one, we are pharmacists. We are ideally placed to detect CKD and NCDs in general, as we are the most accessible health provider in the community. Early intervention will slow the disease progression and help preserve kidney function and improve patient outcomes. So the earlier we can detect this, the better. So let's do it in the community level. Like my nephrologist colleague mentioned, please do your best to keep your patients from coming to see me, because by the time they see me, when they see the nephrologist, they will be in stage 4 and 5, which is way too late to do anything significant to actually help their quality of life. And of course, we also need to be mindful that when we adopt guidelines and or rather resources from FIP, we need to get local buy-in from the pharmacist and the patient, which means that we need to localize the material, then educate the pharmacist, then activate them, and using the pharmacist to engage and educate the public and increase health literacy on NCDs. So I think that's about it. My time is up as well. So thank you very much. Over to you, Lars.
Thank you so very much, Jack, for sharing and showcasing your projects in Malaysia, and also highlighting the essential role of the community pharmacist linked to chronic disease management, and actually how pharmacy can improve outcomes, as well as strengthening the interprofessional collaboration, and also having the patient at the center, because patient involvement is also key to success. I will now ask our dear panelists to turn on your cameras, because it's time for the Q&A session. And also I encourage you as the audience to submit your questions in the Q&A box. We already have some questions for you as panelists. And actually, I will start with the first question. It is from a colleague in Argentina, Jorge Robledo. And he says, some cardiovascular risk factors such as obesity and dyslipidemia begin in childhood, and they should be detected and combated at this stage of life. Is there any advice for early detection in these guidelines? First to Ines, perhaps, and then I would like to hear what Antonio and Jack says about this, about detecting these risk factors in childhood. Over to you, Ines.
Thank you so much, Lars-Åke, for the question. These toolkits are developed by patients in general. They are not particular to childhood, but I think we can adopt, like Jack have said before, we need to study these toolkits, these materials, and then we can adopt to our own practice. And using these toolkits, we can do the same to the population. These are for adults in general, but I think we can adopt for children, because the questions are general, and then we can add some questions for children. I don't know if Antonio or Jack have any kind of experience for this type of population.
Thank you, Ines. I can add something. I don't have too much experience on it, but actually, when I heard the question, I totally agree with it, and I think community pharmacies can actually develop a very important role tackling these subpopulations. We did some work on some chronic disease like asthma already in the past in Portugal. But I'm pretty sure we have to do more, and most of the things that I have showed you in my presentation about the project that we are developing now in Portugal, I think we can apply them also for this subpopulation with a very important aspect here, which is, as the question says, it is very relevant to tackle in these ages because actually the impact we can have on their health is huge. So that's all.
Jack?
Yeah, I'll just chime in. I agree with the premise. Actually, one of the things that we raised with the government recently is that can we actually consider integrating health seeking behavior, health literacy into primary school curriculum, and that's something that we are discussing now in Malaysia, and hopefully if I can get any more information from there, we will actually definitely share with FIP.
Thank you, all of you. Yes, I think this is actually a very relevant question, because, you know, it's about, to some extent, behavioral, how we actually have our lifestyle, etc. And if we actually expose children at an early age for these risks and don't cope with the risks, they might actually, at the age of 20, be suffering from several chronic conditions. And that is not a good start in life, so to say. Well, I will raise another question to Antonio. What about the implementation challenge when you start projects like this? What are the main challenges to successfully implementing these pharmacy-based interventions? And secondly, how can pharmacies ensure effective intervention from patient recruitment and to successful follow-up?
Thank you very much, Lars-Åke, for the question. Well, yeah, there's a lot of challenges when implementing these studies and this project, and we need to tackle them in order to guarantee that in the end we are able to generate the evidence we need to support decision makers to implement for the whole population this kind of project. So patient recruitment and engagement is one of these challenges. Many patients are usually unaware of these pharmacy services, and some of them don't view pharmacies as a primary care provider for this kind of services. So we need to increase the knowledge about all of this. We also have obviously workload and time constraints, but when we compare community pharmacies with other healthcare providers like GPs, actually we see that community pharmacies are more accessible and have more time to do this. So that's a very relevant characteristic of the community pharmacies in order to deliver this kind of interventions. And third, but not least, is the coordination with other healthcare providers. It is very important for pharmacists to feel engaged, to feel the relevance of these kind of projects, to be coordinated with other healthcare providers and not doing this alone or just by themselves, and feel that they are integrated in the whole system. So I would say that these three aspects are very important, and obviously when implementing the project, we are already taking some measures in order to avoid some of these problems and to guarantee that in the end we have a successful project which will show the effectiveness of the pharmacist-led intervention.
Thank you so very much, Antonio. Yes, I agree. Interprofessional collaboration is key, and I just want to highlight that FIP recently published a statement of policy regarding interprofessional collaboration. So please look out for this at our webpage. It's very important as well. Well, Jack, given the prevalence of non-communicable diseases, or NCDs, what strategic partnerships of the future initiative is the Malaysian Pharmacist Society planning to further enhance pharmacy-led intervention? And secondly, how do you actually, what are the key success factors to convince the authorities or the Ministry of Health to view pharmacy as an integrated actor within primary healthcare?
Well, I thanks for the question, Lars. I think well, when it comes to strategic partners, we are looking sideways, above and below, in every angle. Some of them are the pharma companies, the usual suspects when we talk about who pharmacists collaborate with. But increasingly, we are also collaborating with not for example, not with Ministry of Health only, but Ministry of Digital Transformation, the digital Ministry of Communications as well, because we realized, like for example, in Malaysia, the Ministry of Communications has about 900 over sites in Malaysia that teaches digital education, and they are in rural areas in the middle of nowhere with very good internet, for example. And how can we actually reach out to the rural population if we do webinars by pharmacists that actually go to all these areas as well? So we are looking for strategic partners beyond the usual suspects, the usual strategy partners that pharmacists work with, beyond healthcare as well. And of course, the question about how do we make pharmacy more relevant and more integrated, I think a lot of it will come from the public. That's the reason why we need to always remember that the biggest stakeholder in a person's health is not the pharmacist or the doctor. It is the person that because it's that person's health, and that is why we are actually looking on seeing how we can engage community pharmacies more in a preventative care framework, for example, getting the community pharmacies to engage their patients more rather, so that their patients will say, hey, we want our pharmacists involved in the healthcare system. We want the pharmacists involved in the first part of our health, which is prevention, before we actually need to deal with the cure.
Thank you, Jack. I think that's very important to engage with the patient and patient organizations, but because once they know actually what we can do for them, they will advocate for pharmacy. But we, as pharmacists, we advocate for the health and patient safety of our customers or clients or patients. Exactly. Well, Ines, I have a question for you. We know that we have heard about fantastic projects from Portugal and Malaysia, but from your perspective, what policy changes are needed to better integrate pharmacists into chronic disease management teams?
Thank you so much, Lars, for the question. I think the government should start looking to pharmacists and see that pharmacists are healthcare providers in the front line. I think COVID showed us that we are on the front line with the vaccination in many countries. And also we are healthcare providers that could screen and could manage these kind of patients with chronic disease. So I think is our work as an international organization is to start promoting more our work as pharmacists and to provide governments our role. And I think in our tools that I have shown you, not only the toolkits that I have presented you, but also the 5 handbooks and also the knowledge and skills guides, we have a lot of examples that we have shown to prove our role. And one important example that we also have is the work that we are doing in the tobacco field, the tobacco cessation field. And we have now a joint declaration with the WHO. So this proves our important role working in this kind of areas as tobacco cessation is, as tobacco use is one of the risk factors for many of non-communicable diseases. So we are still working, Lars, this is a journey, but we are working to promote our work, our super important work to improve healthcare system.
Thank you, Ines. So we can actually expect more toolkits to support the role of the pharmacist in chronic diseases. Excellent,
yes,
excellent.
And please allow me just one more comment. Yes, we are always working to have more toolkits. And we are also on the tobacco cessation field. We are preparing a new one to launch in November. This is a toolkit to help pharmacists to work on brief interventions. So we have a lot of materials on tobacco cessation, but this new one that we will launch in November is just to brief interventions that all of us could do in the pharmacy every day. So thank you for allowing me to promote this new publication.
Sounds very good, Ines. Thank you. Well, before we wrap up this digital event today, I would like our panelists to, during not more than 1 minute, present a take-home message to all those who are listening worldwide. What are your thoughts? Starting with Jack.
Well, I think for me, it is to actually explore NCD services and reach out to your patients and to see what you can do to serve them better. So that's my take-home message.
Yeah.
Thank you, Antonio.
Thank you, Lars-Åke. To me, it's the same, and just one additional note and take-home message is it's how important it is to find collaborative agreements, find new payment models, and believe that the evidence that we already have, and the evidence that we can generate using these practical tools and FIP tools are very useful to do that and to implement that in our own countries. We are able to generate evidence and transform the way we deliver care through community pharmacies and through community pharmacists to the population in this specific and so relevant area, which is the non-communicable diseases. Thank you.
Thank you. Ines?
So as community pharmacists, my colleagues have said we are in unique position to lead the chronic disease care, and with the right tools and strategies like the ones we have presented to you today, pharmacy teams can play a vital role in raising not only awareness, but also identifying at-risk patients and facilitating early detection and referral for chronic conditions and collaboration, like Antonio said. So my take-home message is by integrating these services into everyday practice, pharmacists can help improve patient outcomes and make a significant impact on public health. So thank you so much for listening.
Thank you so very much, all of you. I would say that the chronic disease framework, service framework, provides a comprehensive strategy to enhance the role of the pharmacist in managing chronic diseases. And I think it's particularly valuable as it sets standard guidelines and best practices that will help you as a pharmacist to integrate more deeply into chronic disease management and thereby addressing a growing global health burden. And I think that one of the primary values of the framework is its support for pharmacists by equipping you with the knowledge and tools you need to deliver effective evidence-based care. And it emphasizes areas like medication therapy management, patient education, lifestyle counseling, and early identification of chronic conditions. And for patients, the value of this framework lies in its potential to improve their access to high-quality personalized care. It positions pharmacists as accessible healthcare providers who can deliver essential services close to where patients actually live and work. And for the perspective of health systems, the chronic disease service framework can be a catalyst for integrated and cost-effective care, because by enabling pharmacists to take on a larger role in chronic disease management, the burden on primary care physicians and specialists can be eased, allowing them to focus on more complex cases. And this kind of, I would say, task shifting not only optimizes the use of broader healthcare workforce, but can also reduce the healthcare costs by preventing complication and hospital admissions related to poorly managed chronic conditions. So in summary, I think this framework, and as we have heard examples from Portugal and Malaysia, offers significant value by transforming the role of pharmacists in chronic disease care, improving outcomes for patients, and enhancing the efficiency of our health systems. So it promotes a more holistic, I would say, patient-centered approach to healthcare and ensuring that chronic diseases are managed with the expertise and the attention they require. Next slide, please. This event can be listened to once again if you access our events.fip.org webpage, and you can also find updates on new digital events in the future. And as such, we also encourage you to provide us with feedback so we can make these events even better for you in the future. Next slide, please. And I encourage you to attend the Congress in Copenhagen next year, the 83rd World Congress of Pharmacy and Pharmaceutical Sciences, with the theme Pharmacy Forward, Performance, Collaboration, and Health Transformation. And we have 3 tracks for the Congress: making it sustainable, making the system work, and making it personal. And we have heard examples of all these 3 tracks today from Portugal and Malaysia. And you have some important dates here if you would like to submit abstracts, if you would like to submit the deadline for the abstracts, and also early registration fee, etc. And attending the Congress is also another way of sharing experiences and learning from our colleagues worldwide. So I encourage you all to book the dates for the Congress in Copenhagen, and I look forward to seeing you all there. And by this, I would like to thank our fabulous speakers today for sharing your experience, your knowledge, your wisdom, and giving us good advice on how to manage this in the future. It has been a most rewarding event, and thank you so very much for attending today as a speaker and panelist. And thank you to all of you worldwide who have been listening and attending this event today. And please stay tuned at our webpage for the upcoming digital events as well. So by that, I will wish you a nice day today and a nice upcoming weekend. Thank you all so